Hello there. I am Melissa Cady, a board certified anesthesiologist and board certified pain medicine physician, and also the owner of Painless Wellness. You're watching this video to get an understanding of what to expect on the day of your procedure. Whether it is myself or a trusted colleague, one of us will speak with you virtually or by phone in some circumstances before the day of your procedure in order to review your medical issues and create a plan for your anesthesia in a less rushed and a more relaxed state if possible. Please bring up your concerns or questions during this visit. You will typically be informed by the surgery center within the week before and or up to the day before as to when you should arrive for your procedure, which typically is about 1 hour prior, but this can also vary. They will review the policies for your day of your procedure and remind you of certain things to do or not to do, including not eating at least for 8 hours prior to your procedure time. However, if you're on any medications that slow your gut, such as Ozempic, Mounjaro, etc., or have any medical issues that could slow your gut, then you may be told to hold solid foods for a longer period of time. When you arrive to the surgery center on the day of surgery, you will be taken back to a preoperative room or area where a nurse will check your vital signs and sign consent forms. You will more than likely be asked to give a urine sample to check if you have any evidence of tobacco in your system, and or if you are a premenopausal female, then also to ensure you are not pregnant. If those items are not positive, then they will have you change into a gown. You may also be asked to take a pill or two, such as Tylenol and or gabapentin, with a couple sips of water. You will typically have your IV placed by a nurse in the preoperative area, so feel free to discuss any concerns you may have, whether it is related to arm restrictions or struggles you have had with getting an IV. Staying well hydrated the day before surgery can be very helpful for obtaining that IV as well. At some point, you will get to meet your surgeon to ask any last-minute questions or to receive any markings or pictures that the surgeon may like to do. Also, prior to going back to the operating room, you will be seen briefly by your anesthesia professional to verify a few things and to see if there are any last-minute questions. When it comes to the ideal level of anesthesia, it is based on multiple factors. The type of surgery is one. 2 is surgeon expectations, 3 is patient medical issues, and other factors as well. But ultimately, your anesthesia provider will decide what is safest for your anesthesia. You're welcome to discuss any concerns you may have with your anesthesia provider. Intravenous or IV sedation with propofol is a common way to create deep sleep for procedures. However, there are common misconceptions. This is within and outside of the medical field that include believing that using only propofol with no airway device makes the anesthesia less risky or more simple. The reality is that a patient without a breathing tube or more advanced airway can make the patient more prone to airway obstruction, leading to an inability to get oxygen in or out of their throat region. In addition, patients receiving deep sedation are not able to protect themselves as well from stomach acid that can passively move up into their throat and or their airway, and yes, this can happen with an empty stomach. The patient's ability to cough things out is blunted if this happens, and it requires an anesthesia provider's attention and assistance immediately. Anesthesia skill is required to minimize catastrophic consequences from these potential issues, but also to determine in advance who is not an ideal candidate for just IV medication with no special airway. If you have moderate to severe gastroesophageal reflux, known as GERD, or sleep apnea, known as OSA, and carry extra weight around your neck region, then an advanced airway or breathing tube will likely be chosen for your anesthetic. Once your anesthesia provider has decided on the ideal anesthesia plan with you, and everyone is confirmed to be ready for you from the surgical team, then you will walk with the nurse and or your anesthesia provider to the operating room and be guided to lie down on the bed. Your anesthesia professional can immediately give you some relaxing medicine and then place your monitors on before proceeding with the remainder of your anesthesia. If IV deep sedation is the initial intention for your anesthesia, then we can achieve that by using mainly propofol. The primary focus is to ensure that you're comfortable and sleeping without any compromise to your breathing. As long as you're breathing well, then we can keep you sleeping well. Many times after you're asleep, we can use a small oral airway to keep your tongue down, out of the way, and allow an adequate passageway for you to breathe without obstruction. In certain cases, when an oral airway is not helpful, We may choose to use a nasal trumpet, which is like a soft silicone straw. We place that gently on one side of the nose with some lubricant after spraying some nasal spray to the nose to prevent or minimize any trauma to the nasal passageway. Either an oral or nasal device allows us to insert smaller tubes within them to give oxygen and also to detect carbon dioxide via our monitors. Most people do not remember anything with deep sedation, but on rare occasions, someone may recall a brief moment of hearing a voice or opening their eyes. Do not worry, we're watching you, we're keeping you safe, and we want you to be comfortable. We can administer additional medication as it is needed. However, without a breathing tube, we do need to ensure that you're breathing well on your own. You will have some IV short-acting pain medications already on board. There will also be orders for the recovery room nurse to give you additional medications as needed for whatever is giving you issues. In many cases, your surgeon uses local anesthesia to minimize the need that day for long-acting opioids. Opioids can be known to cause nausea, severe constipation, and urinary retention. In our experience, most patients do not have nausea from the medications given during our sedation, especially because propofol has anti-nausea properties. There are other reasons that nausea can occur, including withdrawal from chronic caffeine consumption, dehydration, procedure-specific contributions, etc. These can be discussed during your anesthesia virtual. If it is decided to start with or convert midway through sedation during your procedure to a regular breathing tube or a more advanced airway called a supraglottic airway device, which does not go between the vocal cords, then this can be accomplished with just propofol, a volatile anesthetic that many people call gases, or a combination of the two. These are definitive general anesthetics to maintain a very deep sedation. To initiate one of these devices, a larger dose of propofol and other medications are given immediately to induce a very deep sleep. If using a supraglottic airway device, frequently referred to as a laryngeal mask airway or an LMA, then that is placed with a lubricant behind and below the base of the tongue when you are asleep. This device is preferred for those patients who are more inclined to obstruct and to minimize oxygen being released into the surgical area where cautery is being used, and hence to minimize the fire risk. If using a breathing tube, then this is placed while you're asleep through your mouth and between your vocal cords. Placing a breathing tube is typically necessary to optimize the situation for the surgeon's work and to reassure the anesthesiologist or other anesthesia provider that you're breathing without issues and minimize the risk of aspiration in the event that your stomach acid passively moves into your throat area. Your anesthesia professional has access to using a special video scope to see your anatomy more clearly to place that breathing tube. There is always some risk of irritating tissues anywhere from the lips down to the vocal cords. However, we take great care to minimize those things. Most of these inconveniences resolve on their own over days to weeks. It is extremely rare to have serious complications. We will maintain your general anesthesia with IV and/or gas, also known as volatile anesthetics. General anesthesia means you will be unconscious during your surgery. This is not a twilight anesthesia sedation kind of issue. This is a general anesthesia, and it's planned that you are going to be unaware at all times during your surgery. It is normal to be groggy that day and sometimes the next. However, mental effects can come from medications you take after your surgery as well. When surgery is done, you will typically wake up with special bandaging based on the type of procedures you have done. This is usually discussed with you by the surgical team, but we can help you know some of the basic expectations during the anesthesia virtual. Please note that there are times you may receive eye ointment to protect your eyes, which can give you a little bit of a blurriness when you first wake up that day. If your surgery is greater than 3 to 4 hours, then please know that you will likely have a catheter placed sterilely to the bladder by the operating room nurse after you are asleep. However, this is typically removed before you wake up. If you have any issues with urinating the night after surgery, please let your surgeon know as well. Regardless, your anesthesia provider will be giving you several different anti-nausea medications in your IV prior to you waking up from anesthesia. Most patients do not have nausea from the medications given during their anesthetic. If you have severe motion sickness history while in the front seat of a car and not driving, please let your anesthesia provider know, as there is a scopolamine patch that can be placed as part of your anesthesia plan. There is also an oral medication called aprepitant, the brand name being Amend, that can be taken 2 to 3 hours before your anesthetic that affects receptors that are not targeted with our current IV options on the day of surgery. This medication can help you for the first day of anesthesia in a complementary way with our other anti-nausea medicines. Our goal is to keep you safe on a day that many patients are understandably nervous. Please let us know if you have any particular concerns or questions during your anesthesia consultation. And one thing I do want to mention to you is it is extremely normal to be nervous after hearing everything I just said, and extremely normal to be nervous leading into that night before and the morning of surgery. At some point, it is really important that you just trust the people caring for you because we want the best outcome for you. And at some point, you just have to trust that we will look out for you, and that's what we want to do for you. If you have any questions, again, please let us know during our consult. Thank you.